Good morning, everyone. My name is Mallory Zehe, and as was presented, I am a pediatric psychologist at Akron Children's Hospital. And so my primary role and primary area of service is palliative care, where I treat individuals from birth essentially to age 26 with complex chronic medical conditions, excuse me. You'll notice about me, so I stutter. So if you hear pauses, it's my language, that's what you're hearing. When I work with kids and families, oftentimes kids will ask me, can you breathe? And I say, yes, just give me a moment. Okay. So no disclosures or conflicts to address today. My objectives for today's presentation really are to review the prevalence of mental health concerns, both generally and then within the mitochondrial disorder population. Our previous speakers did such an amazing job of highlighting the current research and important aspects to consider in psychiatric presentations in individuals with mitochondrial conditions. We also want to review the impact of cognitive impairment and mental health concerns on the patient and family. I want to define the role of pediatric palliative care and pediatric palliative care psychology and the role that we can play in serving patients and families who experience mitochondrial disorders, and then also discuss assessment and intervention practices to optimize cognitive functioning and mental health in this population. So excuse me, first, why? Why am I here? Why are we having this conversation? And we know that mental health matters in terms of lived experience. So broadly, when we consider mental health, we are looking at the mental, emotional, developmental, and behavioral aspects of an individual's experience. We know that in the general population, and this is data from 2022, so the data collection period preceded COVID, but we know that approximately 20% of individuals between the ages of 3 and 17 present with a diagnosed mental health concern. So we know that in that population, ED visits for mental health concerns for individuals ages 0 to 17 rose by 25% between the years of 2016 and 2019. We also know that there was a 16% increase in suicide in children ages 12 and older from 2008, excuse me, to 2020. So those statistics are likely gross underrepresentations of the actual experience and need, because we know that number one, to assess is very challenging. And we know that many children who experience mental health conditions do not receive appropriate assessment or intervention, right? So we know that these are generally much lower in terms of prevalence. These representations are much lower. I will say also that the data coming out now after the COVID-19 pandemic highlights a drastic increase in mental health concerns across the lifespan, but we know especially for children. And so we're looking at these figures, so 20% being more like 50 to 70%. So really striking stats. We also know that barriers to mental health care exist, and it is estimated that in the general population, between 70 and 80% of children with a mental health condition go undiagnosed. So again, a very, very large number of kids. So in terms of influences on mental health, we know that there is a biopsychosocial model of service delivery, right, of assessment and intervention. What we also know is that individuals with complex or chronic illness experience mental health conditions at a higher rate. And we know also, and I'll get to in a review of what our speakers have already presented, that in mitochondrial disorders, right, we have the unique function of the mitochondria and energy expenditure on disease presentation in terms of mental health. So we know that there are a variety of influences on mental health that need to be addressed. And individuals with complex or chronic illness, in some ways, experience an advantage in that they're being followed by medical professionals across a variety of disciplines, which gives us a unique opportunity to assess and intervene that we may not experience otherwise. So mitochondrial psychobiology, and this is what was alluded to earlier, generally, and this is a very broad and I would say low-level overview, is the study of how the mitochondria impact mental health. We get to the interplay between biological processes and psychological states. And we are looking to understand the biological systems that convert psychological into health outcomes. And so we're looking at health outcome behaviors. We know that disruptions in energy play a role in the expression of anxiety and depression and other cognitive impairment. So why do we care about cognitive functioning and mental health? And it's because it has a direct impact on our daily living, right? Our cognition includes the way that we think, the way that we act, how people experience the world around them, how people learn, how people are able to attend to their environment. From the mental health perspective, actually, let me go back. So in terms of cognition, right, we look at a variety of areas of functioning. And there are some really interesting meta-analyses that have taken place that look at attention and concentration, other elements of executive functioning like organization and planning. We look at areas such as visuospatial, excuse me, memory, the ability to take information and synthesize and learn. When we look at mental health, we're looking at generally, like I said before, the emotional, psychological, social well-being of individuals, and the way that it influences cognition, perception, and behavior. So the difficulty then, right? So we know that there is likely this element that is needed in the care of individuals with mitochondrial disorders. And the question is, okay, like we know that these things exist. What do we do about it, right? How do we intervene? How do we help this identified problem improve? And the answer is access to care, right? So we want to utilize systems that are accessible, feasible, manageable, and make sense. And this is where we have a unique opportunity to utilize palliative care systems to help facilitate that delivery of service. So here we enter pediatric palliative care. So broadly, and I can tell you, so when I was becoming a psychologist and I was choosing a specialty, I knew that I wanted to be a pediatric psychologist, which by name is actually not as it sounds. So pediatric psychologists are individuals who manage individuals with co-occurring medical diagnoses and mental health concerns. So in general language, right, we think of pediatrics as kids and adolescents, but pediatric psychology talks about the interplay of medical and mental health, or physical and mental health. And so in pediatric palliative care settings, this definition from the organization that kind of governs pediatric palliative care talks about how palliative care, without the psychology piece, but palliative care in general, is an interdisciplinary team that provides family-centered care that includes the child and family as one unit of care, looking to really respect individual differences, cultural beliefs, values, and include the child and family in all elements of their care. What we know is that pediatric palliative care teams, generally speaking, and by definition, include multiple layers of professionals, from physicians to psychologists, social workers, child life specialists, chaplains. We're looking at physical therapy, occupational therapy, speech therapy. So typically they're well-rounded teams that then are able to offer a variety of services to support patients and families. Pediatric palliative care psychology utilizes a patient-centered approach that uses psychological assessments and intervention to improve pain and other physical symptoms, but then also to intervene with psychological distress. And so the goal of pediatric or palliative care psychology is really to increase an individual's comfort, well-being, generally improve their experience in the world. And the job of the psychologist, right, is to help individuals cope with stress, loss, changes in identity, and then also to address more existential concerns that are related to complex or chronic illness. So we know individuals with life-limiting illnesses, depending on where they fall in their disease trajectory, what their experience of symptomatology is, that these concerns can look very, very different. And so really, psychologists who work in palliative care are in a unique position to provide more holistic care related to mental health as opposed to more like problem or solution focused areas. So the nuances. So when we're looking at palliative care as kind of a conduit of service delivery, palliative psychology is often, like I said, holistic, more strength-based, and really includes patient, family, and important systems. So we're looking at schools, we're looking at an individual's social network, really incorporating multiple layers of an individual's life to provide the most holistic outcomes. And psychologists in this area may be involved in the patient and family's life from diagnosis through transitions in care. And so transitions in care can look like the progression of disease. It can look like changes in care delivery settings, such as inpatient hospitalizations, outpatient, looking at transitions from home care to hospital-based care, and then also for end-of-life care. So when we're looking at assessment intervention in the treatment of mental health concerns, we know that reduction in mental health symptoms can help people more meaningfully engage in their everyday life. And so the idea is that we want to identify what symptoms are most troubling, and we want to figure out a way to problem solve in the ways that we can, and then offer skills for acceptance and commitment for things that we can't change, right? So we know that psychological principles can help us ease physical suffering, psychological suffering, but that the traditional application of evidence-based therapies might not always work best with this population, right? Because there are a number of factors. And to be honest, I think as a psychologist, one of the things that I hear most often in terms of barriers to care are, well, I can't do 10 sessions, right? Or I can't see you for a 20 session kind of grouping to address concerns related to anxiety. So I think sometimes mental health care can feel very restrictive because it is so prescriptive. So we know that we have these evidence-based models, we have really good research that helps inform our practice, but sometimes it can feel, for lack of better words, it can feel very restrictive because not all individuals, for a number of reasons, are able to engage in the process as prescribed, right? As the evidence or the research would posit. Excuse me. So our challenge then is, how do we provide therapeutic flexibility such that individuals across a continuum of expression of symptoms can benefit? So really, we need to triage needs and then flex our interventions. And this is where the skill in psychology comes from. So this is where the benefit in having providers who are familiar with specific rare diseases, with specific chronic medical conditions become valuable, because understanding that interplay can help you to appropriately tailor interventions to make them meaningful and feasible. So we know, for example, cognitive behavioral therapy. I feel like we hear a lot about CBT in popular culture. CBT follows, I always do this with my patients. So we have thoughts, feelings, and behaviors, the cognitive triad, right? And so the cognitive triad looks at the interplay, thoughts, feelings, and behaviors, and how they all impact one another. We work to identify distortions in thinking, right? Or problems in thought. And then the idea in traditional therapy is to identify where the distortions occur and to provide a more adaptive or helpful way of thinking. Sometimes, right, when we experience a chronic illness, like the worries that we have or the concerns that we're faced with are realistic, right? And so they're not irrational thoughts. the feelings of worry about a doctor's appointment or worry about loss of function or progressive impairment are not only realistic, but they're also happening in real life. Similarly with depression, right? We know that individuals who experience depressive symptoms, oftentimes when I'm meeting with patients, I think to myself, like, yes, it makes a lot of sense to me that you're sad, right? It makes a lot of sense to me that you're having a hard time with X, Y, Z, because these are circumstances that would make anybody upset, anybody sad. And there's not necessarily an end in sight or a resolution in sight to your symptoms, right? And so we know that sometimes there isn't a problem to solve. And that's where other therapy modalities, while not necessarily as heavily researched or spoken about in the field, are just as valuable, if not more, to providing relief and benefit. Some of the other therapies that I found valuable in my practice, acceptance and commitment therapy, which is a third wave CBT intervention that really focuses on acceptance of current situations and then teaching coping skills to help you manage what your current circumstances are. Dialectical behavioral therapy, which focuses on the dialectics of the human experience, really has a more relational focus. And I think in this, I'm thinking about the mitochondrial disease population, there are skills for distress tolerance that have been very valuable to teach and support, in that it gives individuals more control over their emotional experience, right, to the degree that we can. We also work heavily with family-based interventions. So we know that oftentimes with children, they don't exist solo, right? They exist within systems. And so sometimes a family-based intervention also includes those other systems that I talked about, the school systems, other educational or supportive systems. And so we know that while like frank anxiety and depression can be part of the picture, sometimes the distress that individuals are feeling is more existential. Like, what is the meaning of life? Why am I here? What is the meaning of my illness? Like, why did this happen to me? How am I going to live the rest of my life? Right? These are all very common themes that I find in my work and then also in the work of my colleagues. So some other therapies, such as meaning-centered psychotherapy, which involves really looking at the things that bring individuals enjoyment and purpose, and being able to, for lack of better words, lean into those to find moments of joy throughout their day. It all sounds very fluffy, and I want to assure you that the work is far more meaningful than the fluffy label that gets placed, because I think sometimes we undervalue individual choice and individual feelings about our own experiences, right? So we know that individuals who experience any kind of complex or chronic illness have a different experience than a typical population. And I think when we ignore those differences, we really miss out on a unique opportunity to support people better. And that's really what it comes down to, is that psychology in this area and psychiatry in this area are looking to do a better job of supporting the mental health challenges, symptoms, and experiences that people present with. Dignity therapy is a type of therapy that we engage in more towards end of life, and that involves more legacy making. And so it can involve things like storytelling, planning. I oftentimes will work with individuals who are nearing end of life to be able to plan for things that they want. And while this may sound morbid and kind of scary, it is also, I think, a very valuable and impactful element of care in giving people choice even towards the end of life. So this I'm missing a slide here, but I wanted to go over a case example of a patient that I'm currently treated. I've been treating for the last 8 years. It's an individual with a mitochondrial disorder. They were diagnosed at age 3. And so at that point, they came into our palliative care team at Akron Children's Hospital. And really at that point, the role of psychology is to support the family in understanding their diagnosis, right? When you're receiving a largely impactful diagnosis with lots of medical jargon and then implications for what it means for life, that is a very overwhelming experience. And so we know that, sorry, going wild up here. We know that it can be a confusing time, a stressful time. And so the area really lies in support. So this child is now 10 years old, almost turning 11, and she is a firecracker. And over the course of her development, my role has been to support her through understanding her disease, understanding the implications for what her prognosis may mean, what she can expect in terms of decline as she ages, how she experiences the world around her in terms of peers, explaining why she uses a wheelchair, explaining why she uses different accommodations, really giving her opportunities to think through and to problem solve some of the more practical elements of managing life with a disability, but then also giving her the opportunity to process the feelings that go along with it, right? So feeling very sad, feeling isolated, feeling anxious, not wanting to be a burden on her family, right? And so these are all thoughts and emotions that, like I said, she's just now turning 11. I think oftentimes as adults, we don't always think about how kids think about themselves and how they exist in the world. And I think as a psychologist, that's one of the things that I'm most surprised by and most interested in is just the level of detail that kids think, experience, and then bring to their everyday interactions. And with that, right, we know there can be kind of secondary effects in terms of mental health. So all that to say, she is an individual who is currently doing quite well in terms of her symptom management. Something that the parents have asked me about is that legacy making piece and wanting her to participate in some of the legacy making items while she still has a pretty typical degree of cognitive functioning, wanting to make sure that they're doing the things to really emphasize her current experience and not what they expect to happen in the future. Okay, so I always say for psychology, if you're not sure if you can benefit, try it out. There is such still, I think we've come a long way in terms of the acceptance of mental health care and mental healthcare delivery, but there's still a very large stigma attached to receiving services for kids and for families. So a lot of times kids will say to me, like, I don't want to be that kid that has to go to the school counselor. I don't want to have to go to another doctor's appointment. So we try really hard to coordinate services. So if you're coming to the hospital for an appointment, how can I tack on my appointment at the end of your medical appointment? How can we show you that this isn't something that you have to do because you've done something wrong or bad? This is just an extra layer that you have available to help validate your experience. And most of the time, if I can get like 2 or 3 sessions in with a family, we're good to go, right? We just have to get over that initial hump of like, what is this? It's kind of scary. And really helping families understand that this doesn't have to be anything that is stringent and formal, and it's not necessarily a prescriptive experience, and that I have my recommendations, but we really do what we can to make it feasible for you, your family, and the goals that you have for your mental health care.